Good morning and welcome to everybody at this session sponsored by Shockwave regarding cracking calcium best practices to integrate IVL into your calcium management algorithm. Let me say that I'm very excited to welcome you in person after 2 years in Paris. This is my disclosure. This is our program today. I would introduce my co-chair, Kambis Mashayeki. We will have a talk by Anja Oknes, Norway, and 3 very appealing live cases in the box by Benjamin Hunton, by Jonathan Hill, and by Ole de Becker. Our key objectives today it will be to learn about the best practices and tips to optimize application of intravascular lithotripsy in coronary vasculature, to learn new calcium management algorithms about, according to our very expert speakers, to improve PCI outcomes, and finally to be appraised the latest technology advancement of peripheral intravascular lithotripsy for pre-TAVI success and access. Enjoy the session, and I give the word to Kambis for his welcome.
So first of all, it would be great, Jonathan, to have you here as co-discussant as well. Thanks a lot. And we have also an online chat, and Alfonso Jurado, who is a very routine operator, will also give you answers to the online format. So whenever there are questions, please stand up. We have plenty of time, 90-minute sessions, 3 super interesting cases, and I will give the word already to Anja, who gives us a great overview about the technology of intravascular lithotripsy.
Okay. Welcome, everyone. So yes, I'll go through the technology, and we'll look at different calcium morphology where we use IVL, some of the applications, and some of the recent updated algorithms. So originally, IVL was used in the heavy calcified vessel with the concentric thick calcium, with the idea that the balloon emits high radio frequency waves. The wave reflects of the calcium, and this amplifies the pressure up to 50 millimeters atmosphere. So the most heavily calcified lesions demonstrating the most fractures, this due to the dissipation of the energy through a non-calcific wall. So in the DISRUPT studies, the angiographic inclusion criteria was that you had single de novo lesions with a stenosis of more than 70% or a stenosis of more than 50% if you had a proof of ischemia or an FFR of less than 80. A small lumen area of less than 4 assessed by IVUS or OCT. The target vessel was between 2.5 and 4 and lesion length less than 40. Severe calcification according to the MINS criteria on angiographic imaging, or the presence of a calcium arc of more than 70 degrees by IVUS or OCT. So these findings were confirmed by the Angiographic Core Lab and also in the OCT sub-studies. So from that, we then know that that IVL works when you have severe calcium, when you got concentric calcium, when it's thick and in long lesions. But as we know in the studies, as in the real world, the calcium morphology isn't always one certain type. So what about the nodular calcium and the eccentric calcium? So the study found that no matter how the arc of the calcium was, the pulses that was delivered to treat the vessel was the same. And also, no matter what the continuous calcium arc was, the MSA and the stent expansion was equal. So this is an example of calcium fractures in eccentric calcium. This is images from the study. Also, what was quite odd was that we saw that no matter how big the calcium arc was, the visible fractures that you could see were bigger the higher the arc, and also the more fractures you had in the more concentric calcium. But it showed that even though whether the calcium arc was concentric or it was eccentric, the MSA was the same and the stent expansion was the same. And this is thought to be due to microfractures improving the compliance of the arterial wall. And it has been shown by micro-CT, these microfractures that we don't really see in our intravascular imaging. So how about the calcified nodule? So in 94% of the patients who had a calcified nodule, this was in 22% of the lesions, there was more than a 180 degree of calcium arc. Most of these lesions were in the right coronary artery. And the result was that the MLA and the stent expansion was similar in treating calcified nodulus as in non-nodular lesions. And also the greater number of visible fractures in nodular lesion, the better the stent expansion. Looking at the pooled Genta data, the 30-day MACE and the procedural success rate was equal between men and women. So some of the applications of IVL, so we know now that calcium, that IVL works in concentric calcium, thick, eccentric, and nodular calcium. And also, we know that it's a good tool to treat big vessels like the left main, ostial RCA. It's been proven effective in CTOs and vein grafts, and also in long lesions and in smaller lumens. So we'll look at this closer. So this is the coronary IVL system. So all the catheters can be delivered through a 6 French guide. You can deliver 80 pulses and on a regular wire. The diameter of the balloons are between 2.5 and 4. But it's increasingly usual to use the IVL system also in peripheral arteries, like before you're going to do a TAVR, to deliver your large bore if calcified lesions. So the new M5 Plus system is up to 8 French in size. All of them can be delivered through a 7 French guide, and you can treat a long lesion with up to 300 pulses. So what about the calcium challenges in Cto Pci? I'm just going to mention that because when you do an antegrade wiring of a CTO, that's the vessels that has the highest calcium. And I think in this situation, the way you use your IVL is just like treating non-Cto PCI. But if you go subintimal, you'll create this pseudonodula, and I don't think we know the effectiveness or even the usefulness of how to treat and the safety of how to treat this kind of calcified disease. So this is a CTO of the right, and you can see on the IVUS here, you can see the massive calcium burden, both concentric and eccentric calcium. This is after pre-dilating with a 2.5 balloon. And here you see, even though it's thick calcium, the lumen is quite big, so I didn't think that rotablation would be a good choice here because you wouldn't reach the edges and modify the plaque. So a 4.0 IVL catheter, you can see here having a really good result, expanding. And when you choose your balloon, choose it 1-in-1 size to the vessel, and you can do this with your 6 French radial axis. Also, it's smart to reposition the balloon to give your shocks in a bigger area. So this was the final result. Okay, so IVL have been delivered, now in most countries, and this is the modified calcium algorithm by the UK group. This is courtesy by McEntegard. Another version. So, and this tells us that if you have, by imaging, when you have concentric calcium, when it's long and it's thick, you are advised to go straight, and it's deep, you're advised to go straight to IVL. And also, if you have larger lumens, like the left mains and the proximal right, if the vessel is tortuous, you're also advised to go straight to IVL. And also, it's a great bailout tool if your other modification devices fail. So this is a high-risk calcified lesion of the left main and LAD and circ system, and you can see the massive calcium here. So the advantages here, this is a 3.5 IVL catheter. So the advantages of this device is that you can keep your wires in both branches when you have this kind of proximal bifurcation. And if you have a patient with aortic stenosis or the patient gets hemodynamically unstable, you can cut your pulses. You don't have to deliver all of them, and you can also retract the catheter. I don't really find it very often necessary, though. The patient usually tolerates these stent shocks. So this is a IVUS pullback. On the left, you see pre-IVL. And you can see this concentric calcium, and on the right you see already a good luminal gain, and you can see the fractures in the calcium after shockwave. So kissing balloons and a good final result. So this was an MSTEMI that I had last week, 85-year-old guy with some reduced left ventricular function. So he had a Cto of his right and a Cto of his circ. You can see kind of oozing down the circ, but it wasn't. I tried to wire it, but it wouldn't wire with a medium stiff wire. And this is his LAD. You can see the massive calcium and tortuosity, and it needed a microcatheter and a gladius to wire this vessel, and a guide liner to deliver any balloon and the IVL catheter. So even though this is a last remaining vessel, high-risk case, it's important to have efficient tools to treat the calcium, and this was an excellent result. So it can be used in unprotected left mains, and like this, last remaining vessel, tortuosity, aortic stenosis. Thank you.
Yeah, thank you very much, Anja. Just probably one short question or two. You talked about calcium arc, more than 270-degree calcium thickness. But what about lesion length? Do you think it impacts the efficiency? Meaning, sometimes we only see some ring calcification, right? Only on one spot. So do you think IVL can work as well in these scenarios, or would you say this is a case for different device?
You go on, yeah.
No, you mean just by the ring or the whole length?
No, I mean, you know,
Yeah.
if you have only one
Yeah.
isolated ring calcification where the balloon, the non-compliant balloon does not open, do you think it's also a possibility to crack it? Or do you think that the emitters are too far away to crack it?
Well, you know, this is also when you should move your balloon back and forth, right? So you will emit your pulses in different areas. Yes.
Does it work, John?
Sure. I mean, I think if you have your balloon expanded in the midsection of the balloon in the most tightly constrained region where the concentric ring is, there is always, I think, sufficient energy being delivered by the proximity of the emitters either side. So certainly you get a double dose effectively.
Another thing is, what I'm wondering is, I mean, when I used the first balloon ever, there was no coronary balloon. So I just went to my colleague, Professor Seller this time from the peripheral lab, and we started with peripheral and coronaries off-label, right? So, and now we have this great M5, so, which is also, I mean, you can deliver it over just a normal coronary guide wire. So do you think it could be an indication even for long lesions on the RCA, for example? I mean, to use the 60 millimeter 3.5 balloon, I mean, would be very great.
I can see the attraction of it, but remember there is new developments in the coronary balloons coming, hopefully later this year. And so having a longer balloon that gives more shocks, maybe that is coronary specific, is probably the way to go, rather than to use something which is dedicated as a peripheral balloon.
Another thing is that I think when you just start with this device, probably you just take single lesions. But what I realize more and more, that there is a great impact on bifurcations, right? Regarding especially calcified bifurcations. So, what's your experience on that?
I mean, I think we're seeing now that irrespective of calcium morphology, and with the data that Anya presented, that perhaps the prototypical lesion of the concentric one, which we all started with, that the indications now, or the calcium distribution is almost is less relevant now, because it's effective in all morphologies, not just concentric. So I think within a bifurcation where you've got eccentric calcification, sometimes you may have nodules protruding, then IVL is becoming the universal modality. That's certainly my experience.
Yeah.
Just one question to Anya. Which is your rate of imaging before PCI to assess the calcium burden and the length of calcium to choose the better tool?
I think in these vessels, where you see moderate to severe calcium, you should do imaging in absolutely all of them to choose your correct device, and also to see the effect of what you've done.
Okay, so I think then we are ready for the first case, right? So we have 3 fantastic live-in-the-box cases. Thanks, Anya, again, for the first presentation. And now we will have Benjamin Houghton. He will present calcified left main bifurcation. So just into the topic.
So dear friends and colleagues, it's a real pleasure for me to share with you this calcified left main stenosis. So it's a story of an 84-year-old man, which is referred for a coronary angiogram because he has the typical de novo angina. You can see that he's suffering from dyslipidemia, hypertension. And his story starts in March 2015 with a coronary angiogram for positive stress test, showing a slight infiltration of the 3 vessels and requiring medical treatment. In 2021, it was implantation with a pacemaker for AV block, and in April of this year, he developed a typical angina pectoris, and regarding the typical semiology and the permanent EKG electrostimulation, we go for a direct coronary angiogram. So the clinical presentation is quite poor, but he gives an impression of frailty in this 84-year-old, no abnormality on the lab test. You can see the ECG is with a permanent electrostimulation, and there is no abnormality on the transthoracic echography with a normal left ejection fraction. So the right coronary is dominant, and you can see that there is no stage stenosis, but a diffuse infiltration. And before the injection, you can see this important amount of calcium in all this right coronary artery. And when we go on the left network, on the AP view, you can see at the end of the left main this indentation that is also visible in the AP cranial view. And we have also a doubt at this moment on the proximal LAD, just here before this diagonal, and you can see before the injection again the important amount of calcium. When we go on the left cranial, there is again the lesion of the left main and the doubt on the proximal LAD without any stenosis below. And in this spider, and I have to apologize for the quality of the spider, you can see that there is an important calcification, a rounding, calcified and tubular on the left main. So the key point of today is dealing with a frayed patient of 84 years old, a typical de novo angina with a distal left main, with a doubt on the proximal LAD lesion, and with heavily circumfold calcified lesion.
So thank you very much, Benjamin. So, yeah, well, Ole, how would you proceed, and what do you think is the best calcium modification tool for this kind of scenarios? I mean, there are plenty of options, right, to treat this lesion, but nevertheless, what is your preferred strategy? Would you go for atherectomy? Would you just go for balloon angioplasty, or would you just go up front with the shockwave device?
Well, I would prefer to leave this to other people. I'm a structural interventional cardiologist, so I'm not too much in the coronary business. Yeah.
Well, so coming back to you, Gennaro, what would you do here?
It's easy because I know what it.
Yeah. Well, I mean, no. I mean, it's all about your clinical practice.
Yes.
You know what we want to learn.
I think that in this case, an imaging before the procedure to assess the calcium on the left main, that angiographically it's not so evident, but there is. I'm sure that there is calcium, and I think that in this case, with a large left main and with a very 3.5 LAD, I think that shock wave in this case it's fully indicated.
I mean, the question, you know why I'm asking this question is because there are...
Sorry, Camis, it looked like a very short calcium nodule, but it's very important in this case to assess it with imaging, I think, because we don't know really if there is a length of calcium more than 2 or 3 or 4 millimeter, because it's not so evident at angiography. That's, I think that I would choose the right tool after the imaging. This is very, I think that this is a crucial point.
You know, why I'm asking this, especially in the left main, is that there's still, I think, some people we might have concern about, you know, the time of inflating the balloon, right? So, and I mean, is it something that you have to keep into concept, especially, let's say, if the patient has a low ejection fraction? Does this play a role, or can every patient, let's say, go through it without any problems with a long balloon inflation on the left main? Yeah.
Yes, but I have experience with a shock wave in left main, and the rate of inflation, the timing of inflation, is never so long, in my experience, to be not safe. I think that we can try. If you have to use another balloon, a cutting balloon, or scorer balloon, or a very high OPN, I think that the safety is quite the same. This is my impression. I don't know if John agree.
You can always deflate the balloon after a few shocks and then, you know, deliver them 5 at a time rather than 10 at a time. I think it's very safe, and I think the timing can be very short, where you can deliver a sufficient number of shocks, and you can let the vessel breathe, reinflate, more shocks, and just go through that cycle.
Yeah, so probably let a little bit more time in between the inflations, right? That's probably the key
But that's
message.
just normal
Yeah.
left main practice, isn't it?
Exactly.
What's important to say that Ole maybe will show us that the peripheral balloon of shock wave, it's already changed. You can make more inflation in less time. I think that they will improve the same in coronary field. This is very, very important in these cases too.
Yeah, the time actually got half of the time. So you can give the pulses, typically in the peripheral, you have 300 cycles. Per cycle you can give 30 pulses. In the past it was basically 1 second per pulse, took you 30 seconds. Now you can give the same energy, 30 pulses in 15 seconds.
In 15 seconds.
Yeah. And that's important.
This is very
absolutely.
Yeah.
Okay, I think we can go on. Benjamin, with your case, yeah?
We have,
sorry, there's one question, yeah.
You were talking about
the microphone.
I just think the one good interesting point here is, I mean, you have a bifurcation lesion right at that left main. I mean, the opportunity here for shockwave seems to be the easiest is you can protect your side branch. So it seems, why put anything at risk and drill with another wire in the circ when you can just stick a balloon in it?
Yeah.
Sure, absolutely reasonable. So we'll see what you did, Benjamin.
I will try to show everything that you said, and first of all, we can discuss after the
Welcome
first
back
part.
in Toulouse. I'm very happy to be with my friend Bruno Farah and our nurse Melody to share with you this long and tubular left main lesion. You can see, you have seen on the presentation, this long lesion, very calcified, tubular with a tight stenosis in the distal left main. It's a Medina 100 on the previous angiography, but I put a question markers because we're not sure of this classification. And I think today the key data will be, first of all, the evaluation of the left main lesion. And we plan with Bruno to perform an endovascular imaging to appreciate the lesion characteristic and to plan our strategy. Second, to prepare with the best preparation, the calcification prior to stenting, and finally, to evaluate our stenting with another run of endovascular imaging.
So maybe we can, Benjamin, review the angio that we just recorded. First is the AP Codal View. We can see first that there is some degree of calcification, importance of calcification even before injection of dye. Clearly a long calcified left main lesion. And also we have some degree of calcification on the proximal middle AD, and we will maybe better appreciate after what's the problem here. So this is the spider view, so we can see once again the lesion of the distal left main, and it's just at the level of the bifurcation. It seems that the circumflex has a 90-degree origin. The origin of the circumflex is not really calcified, but it's 90 degrees. There is some disease, some ectatic portion at the level of the ostium of the circumflex, and we see after that the degree of calcification all along the proximal and middle AD. This is the AP cranial view, and we can see that after the proximal AD, that is a little bit ectatic, we have still some importance of calcification and probably a short lesion on the proximal middle AD, just at the level of the origin of this small diagonal branch.
So how we plan, we perform an OCT from middle AD to the left main. We choose OCT because of calcification, is more accurate. And you can see diffuse concentric calcification in the middle AD with a tight stenosis on the middle AD, very calcified with ulceration of the plaque. And when we go on the proximal LAD, it's quite healthy. You have some calcification, eccentric calcification from noon to 3, but there is no stenosis. And as you say, Bruno, in the angiogram, when we go on the ostial LAD, you can see this aneurysm dilatation just after a very tight stenosis and massively calcified of the left main. And when we pull back on the mid left main and the proximal left main, you can see again this tubular calcification with ellipticity of the vessel, which makes the treatment and the preparation of the plaques definitely essential. So if we focused on the lesion of the left main, you can see that the MLA is below 6 millimeters square. You can see the second guide wire that we put on the circumflex at 5 o'clock, and there is an ulceration of the plaque at 11.
Yeah.
So, Bruno, we can join our friend in Paris and ask them the strategy.
The strategy.
So I'll ask you the strategy. So maybe, what do you think? According to the OCT, Rino, you said that you plan to your operation according to the endovascular imaging. And when you say the pullback and the angiography, would you go for IVL or another technique?
Well, the lumen is so big here, so rotational atherectomy wouldn't be a choice here. You wouldn't manage to do anything with that. So if you're going to modify this calcium, I think IVL is a good choice. I think an IFR pullback in this vessel would also be interesting up front to address the distal lesion and this lesion to see where you need to focus.
There was a muscle bridge as well, huh? Have you seen it? The muscle bridge?
I think you have to choose a tool here that allows you to do the very exact focal modification of the areas of concentric calcification, and then also the total lesion modification, because there's calcium along this whole vessel. So I think one of the advantages of IVL is that it allows total lesion modification and improvement of the compliance of the whole length of the lesion, not just focal modification. And I don't think you can deliver that with rotational atherectomy. It may deal with it focally, but it's not going to deal with the deep wall calcium along the length of the lesion. And I think IVL is the only modality that can currently do that.
Maybe we can quickly implicate the floor. Who in the room will not prepare this lesion with any tools, with a non-compliant balloon? Who will do that in the room? Nobody. IVL. Okay, not so much.
Yeah.
Rotational atherectomy? Orbital atherectomy? Surgery? No.
Or PCI. PCI.
Okay.
All right, I think we can go on, huh?
So welcome back in Toulouse. I'm very
This is not the
to be with my friend Bruno.
The angio and the OCT evaluation, we do our strategy to do a plaque preparation of this calcified plaque with the shockwave technology. Just to explain what we do, it's a transradial approach, 7 French. The guiding and extra backup 3.5. We already put a BMW wire in the circumflex and a run-through wire in the LAD. So now, Benjamin, you are trying to advance the 40 millimeter shockwave balloon. I think it advanced quite smoothly. I think that the choice of the 7 French here is probably a good idea. And I think that we are close now to the middle AD. I will do a small... I think you are correct, huh?
Yeah, we read the lesion,
yeah,
and we can appreciate the profile of the 4 millimeters balloon.
Yeah.
So our strategy is to deliver perhaps 20 or 30 pulse at this lesion and keep the rest of the pulse for the distal left main.
Okay. So you try to use only one balloon here.
Try to use only one balloon, especially for economic reason.
So four, you inflate at 4, that's correct?
4 atmosphere,
4
delivering the 10th pulses. And you can see that.
Oh, very nice, wonderful. You see exactly what happened, huh?
In direct view, after 8 pulse only, you can see that this calcified lesion has just been breaking. So 20 pulses, there is no footprint on the catheter, so we can go on the preparation of the left main.
Okay, so I think that we are now at the level of the distal left main and ready to deliver the 4 millimeter shockwave balloon. So I inflate at 4 atmosphere. Okay. And then?
So we keep an eye on the hemodynamics, of course, because we are inflating in the left main. And it's 10-second inflation, at least for the delivering. There is some team who make only 5 and after make another run of 5. But you can see the perfect tolerance in our patient and no footprint, at least 10% footprint residual after only one cycle. Another great advantage of the shockwave in this situation, the ability to keep a guide wire in the side branch, which is not, of course, possible with a debulking therapy. So we can protect the circumflex despite we are treating the left main to the LAD.
So we go to the proximal part of the left main, still 4 atmosphere, then we
deliver the therapy till a perfect hemodynamic tolerance of the angioplasty and no shock topics, no premature ventricular beats induced by the IVL application.
So maybe now we can review the result, the angiographic result and the OCT result after the shockwave therapy. This is the AP Codal View, and we can see some improvement at the level of the distal left main. There is still an indentation. The circumflex, there is no evidence of any worsening at the level of the ostium of the circumflex. This is the spider view. Here we see some really an improvement at the level of this distal left main. Remember that on the initial angio there is a very tight eccentric lesion, and here it seems really an improvement. A confirmation also on the spider that the ostium of the circumflex is quite nice. And now we have to look at the LAD. So now, really an improvement also at the level of the mid-LAD, probably a small dissection just before this small diagonal. So we can see on this different angiographic view that the effect of the shockwave have been really be important.
The same run than the first one, coming from the mid-LAD to the proximal left main. And you can see a nice improvement of the mid-LAD. And on the zone that we treat with the shockwave, lumen gain, immediate lumen gain, which is important. And as you say, Bruno, a dissection, locality dissection that we can see at 2 o'clock on this part, confirming the impression that we have on the angiography. This dissection is coming on the proximal LAD just before the aneurysm zone of the ostium of the LAD. When we go on the left main distal lesion, there is a perfect improvement of the lumen without any dissection, and this is a very good result of preparation before stenting, and probably it would be enough. If we focus on the mid-LAD, there is interesting points. You can see at 6 o'clock, at 10 o'clock, a characteristic of IVL with these fractures coming in the deep calcium. And you can also see the dissection indeed at 2 o'clock induced by the IVL. Maybe, Bruno, we can come back in Paris to comment these features.
Benjamin, once you see this kind of imaging, do we need again balloon angioplasty, or can we go now for direct stenting?
It's an important question. I think regarding the pullback of the OCT, I think we have well prepared the lesion. There is a limited lumen gain, which is important. I think this image is important for the flow because we have some characteristic that you mentioned, these fractures. It does not mean that if you don't have any fracture, it doesn't mean that it don't work because you have microfractures. And but I think according to the pullback, the preparation is enough to stent, actually. Another important point is that dissection, and Jonathan will confirm it, it's important because we know from the science that IVL is very safe. And after IVL application, there is only 2% of patients which underwent some dissection, and after stenting only 0.5% in the meta-analysis. So keeping in mind that we are working on frail patient, old patient, calcified lesion with a very safe therapy. And so I think it's an important key point.
Mm.
I would make a learning question for the audience and for me too. How do you choose the number of runs to use? Because sometimes we see that a good result after the first run, but we have other runs to use. You stop if you see the good profile of the balloon. I don't think that you make imaging after every run. It's impossible. How do you choose the number of runs? Because sometimes I am on doubt if stop or use all the runs or 70% of the runs.
You're right. It's an open question. There is multiple, I think, answers. Have you seen on the cases, after only one cycle, there is no footprint on the middle AD. So I will keep the pulses for the rest of the lesion if I have a long lesion to treat. I think it's, again, a costly therapy. So, and we know that there is no heat on the lesion, on the vessel wall. So I'd like to use the whole therapy, the whole pulses of the catheter.
This is crucial.
But it's an open question. I don't think that the science can give an explanation.
I think that once you've achieved focal modification, there's a temptation to stop. But that really then neglects the rest of the lesion where there is calcium along the whole length of the lesion. And I agree with Benjamin, you should use all the shocks that are available and for total lesion modification.
And you place the balloon in other segments.
Absolutely, yeah. So share out the shocks along the length of the lesion.
But it's better to use all the run available.
Absolutely. Yeah. And I think we'll see when we're increasing the new use with nodular and eccentric calcium that you may have to apply a lot more shocks at those segments.
I mean, there's still also the recommendation, right, of the company to use 2 runs at the same spot, correct?
Sure.
Do you think why it is like that? So, I mean, as you have seen here, the first 4-0 balloon, it was, I mean, the effect was there. So, do we need more modification at this spot, or should we just, let's modify the whole plaque, right?
Well, I think there's a dose effect, and I think in the data that we've seen with eccentric and nodular, and perhaps Margaret might want to comment on this, but it's there is a clear dose effect in the densest area of calcium. The more shocks you deliver, the more modification you achieve.
Yeah. After this session, they have to modify a lot of indication, the company, I think.
If we come back on the protocol of the CAD, the definition of device success was a threshold of 30% residual stenosis after IVL. It was a threshold. Maybe we can use it to be sure that the plaque is well prepared.
All right, I think we can go on. Benjamin?
The 4024 drug-eluting stent in order to stent the middle AD. Why this length and this diameter? In fact, we analyze the OCT, and so this gives you, for the LAD, a diameter of 40, and for the length, approximately 24 millimeter. The position, even, okay, we can deploy here. Okay, oh, very nice, huh? I'm at 12 atmosphere, and there is no indentation of the stent on the balloon of the stent, so confirming that the preparation was really accurate. So, Benjamin, we deployed already the first stent in the male AD. Now you advance a second stent. We choose a 4.5 by 24. We calculate with the previous balloon that 24 was probably the good length. So maybe we can do now some tests. The goal is to be really accurate on the position of the stent regarding the ostium of the left main. We have to cover the whole left main till the ostium. Huh? To the LAO cranial view in order to see, and I think that we are quite good for the ostium. We will just control in the AP cranial view that we are correct for the overlap with the middle AD. I deploy the stent. Still no waste, confirming the good preparation. 14 atmosphere.
So there is no residual footprint on the stent. Of course, we will need a pot.
Yeah.
And according to the OCT, we will choose a 5.5 millimeters balloon to optimize the proximal part of the stent in the left main. The position of the balloon for the pot is important to avoid a shift on the side branch. So just we place our marker just in front of the guide wire in the ostium of the circumflex. 5.5 at 14 atmosphere.
The angiographic result after the deployment of the 2 stent and the pot at the level of the left main. We already removed the wire that was in the circumflex. This is the AP Codal View, and we see a quite good deployment of the stent, no residual stenosis at the left main. And this is the cranial view, and we'll see also in this view that the middle AD is correct. Very nice result also on the middle AD. And finally, this is the spider view. Good result at the level of the left main, and no major shift at the level of the ostium of the circumflex, so no need to perform any additional treatment at the ostium of the circumflex. Now, maybe review now the OCT.
So the final run of OCT shows that there is no distal dissection and a mid-LAD stent which is well opposed. There is no malapposition. It's well expanded with a circular form despite the concentric calcification prepared by IVL. And when we pull back in the proximal and in the ostium of the LAD, despite this aneurysm zone, we don't have any significant malapposition on the ostium of the LAD. When we focused on the left main, there is also no residual stenosis, no malapposition, and a stent which is perfectly expanded in the left main. We put at 5.5 millimeters, but we keep a kind of ellipticity on the proximal part of the left main because of the calcification. Yes, Bruno, it was very interesting. We treat this complex and calcified lesion with a novel technique, very simple, very safe, in our old patient, giving some amazing results of preparation without the risk of the other technique. So definitely IVL is mandatory in our cath lab today.
Yeah, I think it was an absolutely great case, Benjamin. Thanks a lot for that. So, summarizing the case, what we've learned actually here is that, as you've seen, IVL can be absolutely safe in left main stenosis. Even the time of inflation of the balloon did not do any hemodynamic compromise to the patient. I think second, what we also understood is how important imaging is, especially to decide which plaque modification modality you use. Here, rotablator would not have any sense. And I think you have also seen the side effect, so the effect of IVL after doing the OCT run again, so with multiple calcium fractures. And last but not least, it's a big advantage to do it as well in bifurcations as we've seen here. So I think it was the best strategy for these patients. So, yeah, any comments from the panel?
Lovely case.
All right. Yeah. So based on the time, we have to go forward directly, and I'm presenting Jonathan Hills with also an interesting case concentrating a little bit more on eccentric calcified lesions. So we're looking forward for that as well.
Okay, well, thank you, Cambis, and thanks to EuroPCR and to Shockwave for staging this symposium. So I'm going to be presenting a case done with one of my colleagues, Dr. Sandeep Kaura at the Brompton Hospital. These are my conflicts. The case is a 77-year-old man with a history of chest pain, end-STEMI presentation, and some significant comorbidities, COPD, AF, and the typical risk factors, and a past history of pulmonary embolism. Unfortunately, in the context of this presentation, he had an echocardiogram as part of his initial assessment, so with severe left ventricular systolic dysfunction with an EF of 26. So, without having seen the angiogram and knowing that he probably had significant coronary disease, we were preparing to do a impeller-supported PCI. Now, I've actually going to go straight into the case rather than having any discussion. What we've done is the typical setup for this type of case. We've put an impeller in situ, and we have significant left main lesion here. And what we're seeing with this first run of OCT, and you can see with this Ultron view, that we have at this distal left main a calcific nodule causing a significant distal left main stenosis with this nodule overhanging the ostium segment of the circumflex. Now, when you look at this type of lesion, the use of IVL, when we originally started doing lithotripsy, it wasn't going to be the first modality that you would reach for. This would be a case where we'd be thinking about a debulking strategy with atherectomy. But we've clearly got a significant lesion, and we know that there is calcium. And as we've heard from the previous case, to do these cases in patients who are hemodynamically vulnerable, and especially when we're doing left main intervention in the context of severe LV systolic dysfunction, there's probably a clear advantage here to be able to do this case as safely and as efficiently as possible, avoid the low flow complications you may get with left main intervention, and to be able to keep 2 wires in. So it's become our default strategy now to treat these cases with IVL first. And as we were learning, as you can see here, this calcified nodule you're seeing on the OCT runs is really a quite unpleasant looking nodule. But we've done our preparatory imaging, and so with the wires going down into the circumflex and the LAD, we're getting prepared to do our first runs of IVL. So the things that we have to think about with calcium modification in the left main with this type of calcium distribution is that there is a very high density, a high volume of calcium at that one point where there is the most significant stenosis. You've got a protuberant nodule, and you have got a lot of calcium to modify. So following on from the discussion that we've just had, then I think this is a time where you need to apply the maximum number of shocks at this very intense sort of focal area where you've got the highest burden of calcium. And so what we're doing is basing the selection of the IVL balloon size based on the external elastic lamina measurements that we get within the proximal LAD and within the circumflex. And we are really trying to do optimal bifurcation modification. We're going to have to apply the shocks at the focal area of calcification, but reserve some shocks for the compliance modification for the total left main LAD circumflex lesion. So in this first segment, you don't have constraint of the balloon. This is within the in the ostial segment of the circumflex. We're not on top of the lesion, but there is still calcium present there. So even though it doesn't seem as if the balloon is doing anything, there's certainly no indentation, what you are doing is cracking the calcium, the deep wall calcium, and changing that vessel compliance. Here we have the balloon across the lesion, this nodular lesion. There is some indentation, and we are applying a whole series of shocks. I think in this case we applied 60 shocks with this balloon, so 4 millimeter balloon, sized according to the EEL in the circumflex. And we can see that there is some hemodynamic change in the pressure when the balloon has been inflated. But having an impeller in this situation actually gives us total stability. We have a protected patient. We were able to concentrate on the technical aspects of modifying the calcium to the best degree here. So we've done our circumflex modification, and now we're going out from the left main into the LAD and applying more shocks into that proximal ostial segment of the LAD left main. And this is the angiographic appearance after the IVL modification. So as is typical within our workflow, we will then do a post-IVL OCT. And what we're looking for is an expansion of the overall lumen. But what we're seeing here is this nodule. There are cracks within this nodule. Now, we initially thought that nodular calcium was not modifiable by IVL. But what we're seeing over and over again, we've applied a lot of shocks to that region, is that you see clear macrofractures, and we know from the histological data that there will also be lots of microfractures. And you can already see within this segment that this ostial segment and this overhang of this nodule from the left main into circumflex, you've had substantial luminal gain already. So we will then do another assessment looking into the LAD to confirm our EEL sizing. We've got satisfactory expansion, left main into circ, satisfactory expansion, left main into LAD. We can then choose our stents and get on with the sizing. So we're using this artificial intelligence software. This is the Ultreon software from Abbott Vascular, so the new way of looking at OCT. And so this is an AI-derived measurement. And we're then looking at the MLD in that region where this is the densest area of calcium, very good expansion. So we'd have every confidence in this situation that we can put a stent in and we would see full expansion. In this case, we used a bifurcation stenting strategy with culotte, so 2-stent strategy. We won't go into why we chose that, but that's probably what we have most comfort with. But here you can see with that initial stent implantation that there was really excellent expansion at the region of the tightest constriction. And then workflow is pretty rapid, wire exchange there, and we then deal with the left main bifurcation. Opening up the struts. And all along with this type of case, when you're working with an operator, I work very closely with Sundeep, there is a sort of sense of calmness in the lab. It's a fairly routine thing now to do, that these cases are using a safe method of calcium modification in a protected situation, and we're really just going through a very strict workflow to get optimal stent expansion in both limbs. So, of course, we're going to be doing our proximal optimization, again sized from the external elastic lamina measurement using OCT in the left main. And our initial angiographic result is actually quite satisfactory. Sundeep looking a bit surprised there. But we're doing our kissing balloon inflation, and we'll follow on with another pot maneuver after this. And once we've done this, and this is all based on our post-IVL OCT, we will then do our final run. So we've done a few runs there, and what we're looking for is the apposition, the expansion, and really looking at the anatomy of the bifurcation. Have we modified the calcium sufficiently to allow full stent expansion? Well, what we're seeing here in the OCT cross-section here is that you've got full stent apposition. We're looking right at the ostium here of just at this bifurcation, so absolutely full expansion here. And remember, the appearance of this was a really rather nasty, unpleasant-looking, craggy nodule, which previously we would not have thought you could modify with IVL. But there's been clear modification here using IVL. We've had 2 wires down at all times, and it's been done with protection with LV support and protection because of 2 wires being kept down at all times. At no point was there any slow flow. And so as we get to the end of the case, what we're seeing is we're achieving a very satisfactory MSA of 8.07 millimeters squared. So absolutely full expansion here. That compared to between 2.5 and 3 millimeters in the osteal segment of the circumflex. So full expansion, full apposition, all done with protection. So in summary, this is a case of use of IVL in nodular left main disease. Imaging is mandatory for left main PCI. And IVL can be effective in modifying both eccentric and nodular calcium to achieve large MSAs and stent expansion, which are known predictors of positive long-term outcomes. And IVL creates microfractures not visible on intravascular imaging, which may permit expansion due to changes in vessel compliance. Thank you very much.
I mean, this was really a fascinating case. really based on the fact, Jonathan, that you modified eccentric calcified plaque. So can you predict that nowadays? I mean, or in how many percentage does it work? I mean, we've seen beautiful microfractures, and we have seen a beautiful MSA, and those are cases where in the past we had recoil. Actually, we didn't know what to do, right?
Yeah, I mean, I think we've been a little surprised at how efficacious it is in this setting. I think we were surprised to see the data from the Disrupt CAD 1 to 4 series of studies where actually you got good stent expansion irrespective of the calcium distribution. Yes, you may see the macrofractures in the concentric calcium, but in fact we know that the mechanism of modification when you've got eccentric is not just macro fractures, but a lot of these microfractures. We see that histologically. And when we're treating these patients, there's a consistent behavior of when you're applying sufficient shocks at an area of nodular or eccentric calcification, that calcium is being modified. And modified in a predictable way sufficient to allow full stent expansion.
I think this is the take-home message here for me. What I've learned new is that on these calcified nodules and eccentricity, you probably really try to get the most impulses there and to be more efficient. So there are several questions.
Yeah, Jonathan, just to be devil's advocate, so I get the sense you're proposing that even with full balloon expansion, you'll still do lithotripsy in those areas. And even if you have balloon expansion, you'll continue to do lithotripsy to get maximal. But my comment, though, is how there's another alternative approach, which would be if you have full balloon expansion, why do any lithotripsy in that area? And once the balloon gives, you've increased the compliance of the area. Why continue to give pulses? Why not take a more conservative approach? Do we know which of those two philosophies is correct? Is there any data to support those two opposing philosophies?
I mean, I think the OCT data supports giving as much of the shocks as possible, and we saw the numbers of shocks that were given in the CAD series of studies. So I think you have to divide your thinking into the focal modification, which you can achieve a full expansion, and then the deep wall calcification that we see along the length of the lesion, which is the thing which affects the vessel compliance. So I think the argument now, it shows that you achieve maximum modification with the more shocks that you deliver. And it would be sharing out the shocks according to the areas of the densest calcification, but don't neglect the areas where there's deep wall calcification.
I would just make the argument that we don't really know, that there's not prospective data to argue why you could not be more conservative. I think your argument's based upon thinking that the more cracks I make, the better the patient will do. And when the only goal was just to change compliance acutely just to get the stent in. Once the stent's in and it holds the benefit, then I don't know what the additional benefit is of doing additional cracking.
The striking fact is when you look at the Disrupt series of studies, the area of MSA after stent implantation was never at the point where you'd done the maximum amount of calcium modification. So if you stick with this sort of focal only strategy, then you neglect the rest of the vessel, and I think you achieve full expansion, greater expansion along the whole length of the lesion.
Okay, thank you.
If you want data coming from the science, I'll give you a rendezvous tomorrow, because tomorrow will be presented the 1-year follow-up of the OCT substudy in CAD 3 and CAD 4. So you have some answer to your questions.
Jonathan, hi, thanks for the case. I want to ask you two things. One is that if you deliver lots of shocks in that nodular part, unlike a rotablation, which selectively ablates the calcium, the other side of the vessel where there's not much calcium, would you soften it more? Because this happened to me a couple of years ago where I delivered 4 or 5 shocks in that place. nothing happened, but when we put the stent in, there was a perforation.
Okay.
Now, my understanding at the time was maybe I delivered too much shocks in one place, it softened the adventitia on the other side, and that may have escaped on the spicule of the calcium. What's your opinion on that?
I think you've got to think about what's the mechanism of perforation in an area where you don't think there is a high burden of calcium. It's probably a calcium spicule or a small nodule that you can't see that's been pushed through the wall. But if you're going to look at what's the alternative? It's using a high pressure balloon in that region where the risk of perforation will be even higher. And what we learned from the CAD series of studies, going back to this, is that the rate of perforation was extremely low. And in fact, in the patients that underwent OCT guidance, it was 0.
Perfect. And the second question is, like the last case, the lumen was bigger, so you couldn't do a rotational atherectomy. But in your case, it was very tight, especially in the circumflex.
Yeah.
So what if you had used the lithotripsy here, where you had debulked the calcium a little bit, and then used the...
Yeah, I think that's an absolutely valid strategy, and certainly if there's any difficulty in crossing, then you have to go to rotational atherectomy. I don't have any personal experience of orbital or IVL but I think it's quite telling that the high volume orbital operators in the US are now almost exclusively using IVL.
So I have
I was just going to comment that, so here we will have the wire bias in these situations with rotablation. I think we've all seen that even though you rota these nodules, you'll always get these big indentations on IVL. And also the combination therapy, raising the safety issue in this area. So I think IVL is very good now that we see perfect modification of the nodular.
For the perforation, I think that we have to take in mind very well that this is not a dilating balloon. If you have a perforation with the shock wave, 99% of cases it's not the balloon, but it's some specule. If you have a perforation with an OPN or with a non-compliant balloon, maybe it's the balloon, because in this case the dilation is 4 atmosphere. It's not a dilated balloon. I think that it's in terms of perforation is safer of an OPN or the other balloon.
Thanks. So there is a question in the back.
So I would like to ask one question for the Benjamin, first question, and the second for Jonathan. So Benjamin, could you please tell us what about to put the stent from the left main to the LAD and then just check the physiology IFR, because the angiographically it was not significant in the middle part of the LAD. Even in OCT you can see the tight lesion.
Yeah, you're right.
So second question to Johnson: have you ever used simultaneously the kissing shockwave? Is it possible? So is it real?
It is possible. I haven't done it. I've seen it done, but I think there are probably a few people in the audience who've done it.
Oh, thank you.
Canvas is smiling.
Yeah.
Actually, we have we had 2 generators, but I do it sequentially. It's also a term of economical cost, to be honest.
And for the purpose of the physiological assessment here, you're right, but it was not the purpose of the symposium. So only to show the plaque preparation, but the patient become asymptomatic after this intervention, to answer your question.
Thank you.
Yeah, a question.
Great presentation, Dr. Jonathan. I have seen a similar case with a lesion in the ostial CX 1 year ago in the Netherlands. Full balloon expansion, compliant balloon expansion, has led the operator to implant a stent directly from the left main to the LCX. And then we were faced with a recoil issue involving the ostium of the CX again and again, and nothing worked, even using the non-compliant balloon, using the OPN, and even using the shockwave in that area. Post-stenting wouldn't relieve the calcific nodule that we have seen after stenting, of course, with the IVUS. So I'd like to ask about how the use of shockwave intravascular lithotripsy after the stenting, can it lead to improvement of this recoiling issue or not? Thanks.
I think, though, the recoil in this situation that you're describing is most likely due to a very highly fibrotic lesion where there is a retention of the elasticity that's causing constriction, that you would be able to counteract that with a higher strut, with a higher radial force stent. But the question regarding calcium modification after stenting, yes, it's possible, but I would say it's better to do it before than after.
Of course. We have seen after stenting, we performed an IVUS after stenting, of course, and seen the ugly-looking calcific nodule penetrating with the stent just overlying the calcific nodule and not being able to overcome it.
Yeah.
That's it. That was the problem. So, of course, the full expansion of the balloon does not exclude the presence of any calcific nodule that may appear later. Yeah.
Yeah. Yeah. Agreed. Yeah.
Okay, so let's move forward, and now we go to the peripheral use. Ole de Bakker will show us a great case where I used the peripheral M5 for preparing access for TAVI procedure.
Yes, thank you. I'm happy to pull you into the world of structural heart disease, structural heart interventions after two really nice coronary cases. And so it's IVL-assisted transfemoral TAVI. So this case is a 77-year-old male presenting, of course, to us with severe aortic stenosis, NIA class 2B, prior CABG, atrial fibrillation, dual chamber pacemaker, and he's referred to us for TAVI. He has a preserved ejection fraction, echo confirms severe aortic stenosis. I don't want to go all too much into detail there because I want to have the time to focus really on that IVL-assisted transfemoral part. Still, you can't show any TAVI case without showing the basic measurements at least. So here you see the annulus and the LVOT measurements. It's a medium to large sized annulus. There's no calcium at the annulus level. Sinus ST junction measurements. These are all standard measurements for our TAVI. Coronary heights, no issue here. And then, well, we see really nicely, severely calcified leaflets, nicely symmetrical. So there's no doubt about the severity of his aortic stenosis, but a great case for TAVI, I would say. And then, of course, we look also to the aortic arch. There's a bovine arch here, where I was using cerebral embolic protection. Okay, let's focus on the axis. So then you have this male sent to you. You see, first of all, it's a straight vessel, but maybe I can show you more here. Then it's a plane. This is from the Trumencio, the preparation. So first of all, you see it's a nice straight vessel. I look to the femoral bifurcation where it is. It's nicely distal of the femur head, so no issues there. And then you see I'm walking first here in an analysis through his left iliac and femoral. These are the measurements here on the top corner. You see the diameters of this vessel. So you see the measurements here, they go up to 3.8, even at a certain stage, 2.9. There's quite a lot of calcium there. So maybe, I guess in many centers they would say, well, this is not a real good candidate for transfemoral TAVI. On the right-hand side, you see the same calcifications all over the iliofemoral axis. Here, it's 4.1 circumferential calcification, 360 degrees. But still, I think these particular cases, I want to show you that these are great cases for IVL-assisted transfemoral TAVI. So it's really to push the limit and keep your transfemoral route for TAVI. So what do I have? So we have analyzed here. I know it's straight vessels, which is favorable because a combination of tortuosity and calcium, I would say, then probably I'm going to look really for an alternative axis. But here it's a straight vessel. It is calcified. The lumen is small. The best part is the right, and there the right iliofemoral axis. And there I have, on particular spots, I have as a small lumen as small as 4.1 with circumferential calcification. But I think these are really good suitable lesions. This is the algorithm actually that we use in Copenhagen. So what kind of patients or how far, what is the limit that we accept for these IVL-assisted transfemoral TAVI? Well, it depends, of course, first of all, of your lesion length. Sometimes it's more focal, severe stenotic calcified lesions in the common iliac artery. Then I think you can even really push it really low to minimal lumens of 3-4 millimeters, depending on then the circumference of your calcification, your calcium arc. I would say if it's a focal lesion and it's 270 degrees calcification, like a horseshoe shape, I can even accept cases up to just 3 millimeter of lumen that I measure on my CT. So you see, you can really push the boundaries there. I would say in the beginning when you start with it, that's maybe not the case you have to start with, but it is safe to do this. We have done many cases of this in Copenhagen with good results. So what was the approach for this particular case? IVL-assisted transfemoral TAVI. We just do that in local anesthesia. We don't use any general or conscious sedation or anything for our TAVIs, also not for these IVL-assisted transfemoral TAVIs, just purely local anesthesia. Shockwave M5 plus balloon, 7 millimeter. And then in this particular case, you can do it with any TAVI valve, I would say, but we went here in this particular case for an accurate valve, which you have to introduce to a 14 French eye sleeve. So let's show some images here of the case. So I think the video will start to run soon, or maybe I have to start it. No, it's coming now. So what do you need? It's very simple. So this is now a contralateral safety wire that I'm placing at this particular moment. It's not an absolute must, but you can do it. What do you need? You need just a 7 or 8 French sheets in the axis, in the puncture site where you're going to introduce your TAVI introducer site. You need just a coronary wire, so also these peripheral balloons, they fit on a 0014 wire. So here I'm showing you the balloon. It's a 6 centimeter long balloon. It's typically, personally, I use a 7 millimeter balloon of the shockwave. How to make that choice of 6, 7 or 8? Well, it's not, I don't look to the reference vessel diameter, or it's mostly I'm looking to what kind of introducer sheet or size of delivery system do I have to push here through this iliofemoral axis. And typically then with the current TAVI devices we have, it's around 6 millimeter, but then I add 1 millimeter for some, because there's always a little bit of recoil you can anticipate. So these bursts, I said already, it's 300 cycles in a balloon. It's 10 cycles of 30 pulses, so 300 pulses in total. And here you see, so it's this is the axis, the right iliofemoral axis I'm going to use for TAVI. This is my shockwave balloon, which was introduced through an 8 French sheet on an 0014, just a BMW or extra support wire, coronary wire, and I do the inflation. I start from the top and I work my way down. So I start, of course, at the iliac bifurcation level, even it's slightly going into the aorta here, you see. This is my setup, not always, but you can do this. This is with the safety wire in place. And of course it's a good thing to do that because safety is essential, I think, and these are the more challenging cases you're doing with transfemoral TAVI. And a classical transfemoral TAVI, I'm not using a safety wire at all, but these are more challenging cases, so I think it makes sense to have some kind of safety wire, contrary ipsilateral, especially if you anticipate, not so much I anticipate problems at the IVL treated part, that I almost never saw. Only 1 out of 60 cases had once still a spiral dissection, but in 59 out of 60 it was completely successful and without any complication. It's more because you're concerned about the puncture site, and that has nothing to do with your IVL treated part. Is because these patients, they also have a calcified or a nasty puncture site, and then you have more risk of vascular closure failure. So it's more to catch up on these complications that I, in these particular cases, like to use sometimes in a safety wire. So you see, I worked my way down with this. In the meantime, a couple of series. It takes a couple of minutes, of course. It prolongs your procedure with, I would say, 10 to 15 minutes. But of course, you can. The beauty is that you can keep on doing a procedure transfemoral. An alternative axis is much more complicated. You lose even much more time there. So it's a limited time loss. So then here we did the whole pre-treatment with the shockwave balloon, and then now after that you change your coronary wire to, of course, a super stiff wire, and then you introduce your introducer sheet. This is the 14 French sheet, the eye sleeve sheet that's needed to introduce the accurate valve. And you see there is some resistance here, but I'll work my way down. And what you want to obtain with that IVL is to really, as Jonathan said, you want to modify that vessel compliance. That's what you want. You want to make these microfractures, the vessel compliance, and then with the balloon you get the luminal gain. Yes. So because this patient you saw on CT was only luminal diameter 4.1, but you get that luminal gain in a safe way. You get it up to 6-7 millimeters. And then of course we continue with our TAVI. You see some of our EP guys, they had some fun there, putting a lot of pacemaker wires there. I don't know why all that metal thing is in there. Okay, this is also a patient with a lot of cardiovascular prehistory with CABG, some pacemaker, probably redo pacemaker stuff. And okay. Now the TAVI goes in, and we go quickly over this. It's just a regular TAVI implant, and which I can tell you goes fine. So here, this is then that particular accurate device. Here we have the Safari wire in place. And you see all this goes rather easy through the, it's an expandable sheet, this eye sleeve. So as soon as that introducer sheet, also if you work with expandable sheets, if that's the case for Edwards or for this accurate, for example, as soon as you get an introducer sheet, you will also manage to get your TAVI device and your delivery system through. So that you feel a little bit of resistance, but nothing particular. And what you want to obtain by making that vessel more compliant and getting finally that luminal gain is, of course, that you do this, you can obtain this without paying a price of a vascular rupture or a massive dissection. That's what you want to avoid. So this is the TAVI. You see it's a good implantation, only a trace to non-leak. So we're done with the case. We do a post-dilatation here, so I was even not satisfied despite this kind of trace, but okay, we wanted to see a perfect result. And then I think, I'm not sure if we show in this video the final aortic root injection. Yeah, we do. So there's zero leak. And then we go to the closure, and you see this is a control angio, and that's the classical angio you see. So it's what you often see is that this vessel looks better. Now I typically don't make an angio up front because I just completed my CT, but if you would do that afterwards, you see a better, you did actually a PTA of this for this patient. And it is a little bit true that in a couple of patients who were presenting with severe aortic stenosis and even a little bit of claudication symptoms, actually this patient was not only relieved from his aortic stenosis, but also didn't have any claudication symptoms afterwards anymore. So, what do we do already for 3 years? We do a fully percutaneous TAVI program, and I think that's where Shockwave is really great. It's really to if you want to keep your TAVI program as minimalistic and fully percutaneous as possible, and I think really that's the way to go and where most centers are going. So what do we do nowadays? I think because we're even treating lower risk patients, this percentage goes even higher to, let's say, 93% of cases we do the classical transfemoral. Then there are these tougher cases with calcium, small luminal diameters, like the case I showed you. We can keep the transfemoral pathway by choosing 3-4% of cases are good for this IVL-assisted transfemoral TAVI. That makes that we can do our whole TAVI program of more than 400 cases by 97% transfemoral. Then we do 3% percutaneous transaxillary, and then it's very few cases we only need for transcaval. So you see, you can do your whole program without refusing any patients fully percutaneous. So that's nice, I think. What is the experience so far? We did 60 patients in Copenhagen. I would say, where is the place to use that IVL? Well, 2/3 of these patients were really patients that if I wouldn't have IVL on the shelf, I would probably consider an alternative access, probably then percutaneous transaxillary or maybe even transcaval. So where I would really be scared of not doing it, but with the IVL, it pushes me and brings me to do a safe transfemoral TAVI. In 18 patients, I would have maybe still gone transfemoral, but then I would have taken more risk. And it's, of course, with the IVL, I think I really reduce the risk of major vascular complications like the vascular rupture, like the spiral dissection, as I said before. So as a final concluding slide, I think for me it's a new second-line strategy, that IVL-assisted transfemoral TAVI. It allows me to keep the patients or to treat the patients transfemoral. And it is a lot of benefits. It's more practical cath lab setup. People who have done alternative access TAVI, it's just... you go out of your comfort zone or your routine. Everybody is, it takes much more time. You take much more radiation as an operator too. Here you can just stay transfemoral. You're not standing in that X-ray beam like you're doing transaxillary or transcarotid or whatever approach you want. Also, the TAVI devices are designed to be deployed transfemoral, so it works the best transfemoral route typically, and you don't have any surgical wounds, etc. You can keep it fully percutaneous. So overall, I think it's better overall outcomes compared to transthoracic for sure, like transapical or direct aortic. And also still, if I can do a transfemoral, I still prefer it over percutaneous transaxillary. Why? Because there is some data, even in my own center, but also in the literature, that you have kind of a double stroke risk if you do transaxillary. Even though it's low in the classical population, to me it's 1.5% of strokes we see, but we see it up to 3% in transaxillary. So if we can keep it transfemoral, we keep it transfemoral.
Thank you. So, Ole, may I ask you a practical question? I mean, this is an 60 millimeter balloon on an 0.14-inch wire. So, and sometimes we face also tortuosities. So, did you ever have problems with the balloon delivery?
Yeah, no, I actually never had. But of course, look, I mean, like tortuosity and calcium, then these cases I disqualify for transfemoral, even for IVL assisted. So, but if you would have, I mean, I think you could easily still. There are many solutions I can immediately think of. I mean, you could go otherwise with another smaller balloon up front to deliver your balloon, or you could use kind of an arrow sheet where you could place it up and then to deliver your balloon there and bring it down and work your way down like this. So there would be. I've never been in this situation, but there's many solutions I could immediately think of.
And which extra support wire are you recommending?
What do you mean for the coronary extra support? Or?
Yeah. No, you need a 0.14-inch wire, right? So do you use?
No, but I have. In majority of cases, just a BMW was enough.
Okay. Okay. No, I mean also mother and child cutting would be an option, right? To deliver it.
But indeed, you don't need, like in coronaries, you don't typically need a guiding catheter, for example. You don't need it. So
sure.
In the majority of cases, not. And otherwise, I think I would go just with an. Then you place an 8 French arrow sheet, for example. Like you don't need that much distance, and as the coronary says.
Ole, just one question. I'm used to use all the runs in femoral more than in coronary in all segment of iliac femoral axis. All the runs. This is a suggestion for the audience too. Don't miss one run because it's very important to use all the runs. And finally, after the shock wave, I'm used to use a usual balloon to make just a massage of the femoral iliac axis. What do you think about this?
No, that's true. I mean, I didn't mention this here, but it's true. Even myself, in the majority of my cases still, I use my IVL balloon to modify my vessel compliance, to make my microfracture, my cracks. And then still, especially in these very tough cases, this was now for me even a mild case in a way, but if it's more calcified and over the whole length, then I like to go after with a non-compliant balloon, like a 6 or a 7 millimeter, a ZMET2 balloon or a Mustang balloon, or to get really the maximal luminal gain, and then you go in with your introduced sheet. A good comment. Yeah.
Can I? So, do you have any preferences about which sheets are best in this? Like, you want to go sheetless with like the Corval, or you want to have a sheet in there?
No, you don't have to have. I mean, I've done like Evolut or Navitor with the sheetless approach. That's also possible. I mean, but I gradually work my way up. So typically, if I go then with a 14 or 16 French, I wouldn't go immediately with my full. Then I take my dilator, for example, and I already dilate up. I don't do this with regular transfemoral TAVIs, for example. In these particular cases, I do. Yeah.
So unfortunately, we are running out of time. I only want to thank again Alfonso on the chat. He did a great job. There were a lot of questions. He replied to all of them that we did not have to address them here. Some of the answers we also gave, and we'll hand over to Gennaro for final remarks.
Okay, just 2 minutes to thank you, to thank the speaker and the Shockwave for the invitation. Just to make a summary, we saw very interesting case, calcified left main bifurcation by Professor Honton and Bruno Farah, with this wonderful demonstration how you can treat a left main, a calcified left main with a shock wave. The second case by Professor Hill, eccentric calcified lesion. It can look a simple case, but no case is too much simple if it's a left main, because if you perform an optimal PCI, you can save the life of the patient. And the third case by Professor De Becker, a pre-TAVI. I think that the shock wave really changed the story of the TAVI, because before the shock wave as tool in TAVI, we had a lot of 15% of cases of not transfemoral access, and believe me, the non-transfemoral access in TAVI, it's really very, very difficult and challenge procedure. After shock wave, we had a drop of the non-transfemoral access, and I think this is very important. That finally, for a coronary intervention, I think that the new concept, we have changed our mind. The new concept is do not only delay, but accurately prepare the lesion, because the proper lesion preparation is needed, is strongly needed in severely calcified lesion prior to PCI. And intravascular lithotripsy is designed to treat both intimal and medial calcium, allowing vessel expansion with minimal recoil and decreased occurrence of flow-limiting dissections. So this is very important. And IVL treatment in highly calcified coronary arteries is highly effective for delivery of stents, optimal stent expansion, and improve outcome. Thus, don't only delay the lesion, but go beyond this. And imaging, this is very important, it could be fundamental to better achieve and treat calcium burden. In TAVI field, Professor De Becker showed us how it's important shock wave. So far, alternative access was required for 15–20% of TAVR cases, and alternative access is surely associated with longer length of stay and more complication, high stroke risk, in particular for transsubclavian and axillary TAVI. IVL has been shown very effective in highly calcified iliac arteries to enable delivery of large TAVR delivery systems and change our way to do TAVI. I thank you for your attention. I thank you, the speaker. I thank you, Cambis, and enjoy PCR.